Welcome to the Critical Care Obstetrics podcast. I'm Stephanie Martin, Medical Director at Clinical Concepts in Obstetrics, and I'm here with both my partners, Dr. Suzanne McMurtry-Baird, our Nursing Director, and Julie Arafay, our Simulation Director at Clinical Concepts in Obstetrics. So today we're kind of doing the opposite of what our last podcast was, and we're going to talk about green flags in healthcare. And like I said before, this was inspired by a lot of things I was seeing in social media or that we were seeing that, was like red flags and green flags in relationships. And it got us thinking about red flags and green flags in healthcare, both clinically, actual clinical red and green flags, but also, in the cultures and in the healthcare environment itself. So today's about green flags. But before we get started, we want to remind you about ways you can connect and learn with us beyond the podcast. At the Critical Care OB Academy, you'll find a full library of online courses that we've designed to build confidence and skills in managing high-risk and critically ill obstetric patients. You can support our mission and help us do what we love to do on Patreon at patreon.com/CCOB. At Patreon, you'll get access to exclusive videos. You'll get to interact with us directly. We've got some live sessions on there and some deeper teaching points and pearls. If you want to watch us, we're on YouTube. Just search for the Critical Care Obstetrics podcast and connect with us on all of our social media platforms. So let's move on to the podcast. So green flags. Julie, you want to start us off with a green flag?
Sure. I have a green flag. And when I talk to the simulation team, and at least one of them has had simulation instructor training, that is a green flag for me, particularly debriefing training. So that is a huge, huge, huge green flag because many times people think if you can educate, you can run a simulation, and it requires a different skill set. It's not teaching, and particularly the way I prefer to do simulation, it's practicing. So helping people practice is different than teaching people. And one of one of my colleagues that I learned a lot from always said, "You are no longer the sage on the stage, you are the guide on the side." And when you,
I love that. Wait a minute, say that again.
Yeah, I like
that
that.
was like, I've never heard this one, Julie.
Yeah, I haven't either.
It's not original to me. You are not the sage on the stage, you are the guide on the side. And that is difficult transition for a lot of people that are used to just teaching, because if you don't have a lot of time to teach, you're like, okay, I got to get all this information in. I got to do it fast. And you just start, okay, they're not getting it. Okay, I'm just going to teach it to them. Well, that's, yeah.
This is classic Julie. Like she's just casually in conversation with us talking, and she drops this bomb that is like a game changer in terms of how Suzanne and I look at things. Like, I don't think you understand like how differently you view the world of healthcare, and your insights are so powerful. And you're just like, oh, by the way.
I know. I feel like I need to, I don't know. It's just mind-blowing to me, Julie, when you say these things sometimes. And yeah, Stephanie and we have a little bit of a lot of different kind of sides of our brain that I guess we use. And then I'm like, well, no wonder I'm not that great at simulation. It's like, because I don't think that way. But then when you say it, I'm like, that makes total sense.
Yeah.
Yeah.
Total sense. It's brilliant. But you're right. Like I've been in a lot of simulations, and I've seen a lot of simulations where when you have somebody just, they're telling people what they did right and wrong or what they need to do, that's not an effective simulation. People need to feel it. They need to understand it.
Well, and they need to practice it, and they need to talk to each other and learn from their team members what works, what doesn't work. And one of my favorite questions that I ask the different disciplines, what do you need to successfully do your tasks? What support do you need? What supplies do you need? What space do you need? Because when you understand what it takes for someone else to do their job, you can facilitate that much easier than trying to read their mind.
Well, and when we're with you in a simulation and we're watching that and we're watching you ask that, you can really engage as physicians
Mm-hmm.
and the
Yes.
anesthesiologist. They they really, I mean, they really want to be asked that, right? They want to everybody on the team to understand it is that,
Yes.
and that may be one of the most difficult clinicians to get into the practice. And once you get them there and you ask them that, they're like, nobody's ever asked me that.
Yeah. Yeah. They're like neonatology. They're kind of an afterthought in an OB emergency in
Mm-hmm.
a lot of different settings. Not for everyone, but
Mm-hmm.
for some. And never is their place set up the way they need it to for one of the most difficult tasks, which is intubating during
Yes.
pregnancy. Totally tough task.
Right. Well, I often think they don't know exactly what their role is supposed to be, especially if the patient is delivering too at the same time. Or let's say they were doing a cesarean section, at the bedside, because mom's coded. You often find them in the practice kind of, hesitant almost. They know they're supposed to be involved. They know they're supposed to be involved with the airway. They know that they're supposed to be kind of up at that head of the bed, but still they haven't pushed the bed out or from away from the wall. They still haven't really gotten behind, you know what I mean? So
Mm-hmm.
they're kind of off to the side oftentimes. That's just what has been my experience in watching them in the practices.
Well, I
Yeah.
think it's because if you're not viewing the simulation as how do I, what's the most efficient way to accomplish the tasks that I need instead of education. So if they're viewing this as an education, they're thinking, I know how to intubate a patient. I'm up here
Mm-hmm.
Exactly.
and therefore I am intubating the patient. But they're not practicing what needs to physically take place in the room in order to accomplish the intubation. Of course, they know how to intubate a patient. They're an
Yeah,
anesthesiologist. This is what they do.
exactly.
But that's not the point. The point
Right.
is, has somebody brought them all the tools that they need? Is there room for them to get behind the patient? Is the bed flat? Does the team know that they're intubating and what they need to do in response? Like, is the oxygen set up? Do they have suction? Like, those are the things,
Yes.
not teach the anesthesiologist how to intubate.
Yes. And how do you do those things consistently? That's the
Yeah.
key part, I
Every single
think.
time.
Yeah. How do you make it that way? How do you set that up for them every single time? Or at least have some of these initial things done so that it's easier for them to get behind the patient and really bag effectively.
Well, and when I see, a facility that has committed to training to number one, having a simulation program with
Mm-hmm.
a trained simulation team whose job is simulation, not an add on to whatever job they also are responsible for, education or whatever else they're doing. To me, that's a major green flag because it not just because of what we've been talking about, but also because it demonstrates a commitment on the part of the institution to improving efficiency and processes. And it means, that we're not leaving things to chance. We're not leaving things to luck. We are actively understanding what's working and what's not. And
Mm-hmm.
that's going to improve your culture on your unit. It's going to improve your nurse orientation process, your nurse retention. Physicians commonly work at multiple institutions. And so if they're not able to participate in simulations at that one facility, they may not know how it's done there. They may be, it's hard to remember all of those things. So
Yeah.
practice is so important. So to me, that's a major green flag.
Yeah.
Huge,
Yeah.
huge green flag.
Big one.
Can
I've got
I say mine?
of
Or
course.
you're going to
Yes.
go?
No, go.
When I walk on a unit and see everybody having a stethoscope on,
I love that.
Oh,
you
that's
knew
a
I
good
was going to
one.
say that, right?
And it's not the baby stethoscope.
No, some, a mama stethoscope.
Yeah.
I know, right? Because
I like when I see people in rooms and not on the unit.
me too. Okay, that's another green flag.
Yeah.
When they're actually at the bedside assessing the patient
With a
instead of
stethoscope.
with a stethoscope, but they're not sitting at the nurse's station interpreting the fetal monitor strip and doing their documentation from there. Those are two big ones for me because both of them involve the art of assessment.
Yeah.
And And this was on social media recently, again, about somebody said, who really actually takes a stethoscope and listens to the patient's lungs at least once a shift?
What they were implying that people don't? Like, what do y'all do? Like, was this a nurse?
Yes.
Okay,
Mm.
disturbing.
Yeah.
Very.
And there were a lot of nurse replies saying they didn't do it.
Wow. Is this what is this? Do you think this is generational? Is this regional? Is this specialty
don't
based? Like what's
I don't
happening?
know. I don't know because I've never worked med surg or anything like that, but I know in OB and in all hospitals I believe that we've been in, they have a requirement that once a shift you do a head to toe assessment.
Mhm.
And obviously when we are consulting with hospitals and teams and in real life, we're knowing that the acuity of patients has gone way up and patients are sicker and have more risk factors. And everybody says that and
Yeah,
wants
no
more
one says,
education
"Oh,
on it.
our patients are lower risk than they were 10 years ago." No one.
No
No
one,
one.
right?
Mm-mm.
And yet we're doing less physical assessment. That doesn't make sense. It doesn't match the clinical picture. And also during that time, we've seen maternal morbidity and mortality go up so much. It's like, what are we what are we doing? Like we're assessing less. But the assumption being is that we don't need to assess because she didn't have risk factors or she doesn't have any risk factors or she's doing just fine or she looks good and she, you know,
Until she doesn't.
until she
Yes.
doesn't. So we're not listening to breath sounds. Even and a lot of the comments were, I'll do it if they're on MAG.
Why MAG? MAG doesn't cause pulmonary edema or respiratory insufficiency.
Exactly, exactly. But I'm assuming that because she has preeclampsia, which is a good thing because you should be listening to breath sounds on patients who have preeclampsia because of their risk factor of cardiogenic and non-cardiogenic pulmonary edema. But it was just shocking that everybody just said no. And then there were many, many what they self-described as older nurses that said, absolutely, we've always done it that way. We're going to do it that way. But I don't know if it was, not everybody declared what their age or their generation was, but it was shocking just to see how many people weren't listening to breast sound.
One of the reasons I'm asking about the generational thing is because I'm wondering about is something changed in the training process? Like, are
Yeah.
older nurses trained differently in terms of the importance of an assessment compared to nurses who were trained more recently? Or I don't know. I don't know
Well,
anything about that.
having taught in nursing school for many, many years, I know our nurses were taught that. But I think it's the assumption that they're, labor patient, that they're low risk.
Until they're not.
Yep.
Yeah.
Not good.
So what's yours?
But I thought that was a good one. I have a few, but I think one is, interprofessional respect. And I mean that more than just being nice to each other. I mean, I think that's that's part of it. You don't have to like each other in order to respect each other and be nice. It's phenomenal when you like each other, but it doesn't have to be that way. But what I mean is respect for what every person in the healthcare team brings to the table, because we are trained differently. We do have different backgrounds, different experiences clinically and non-clinically, and all have something to offer. So just because I'm the physician doesn't mean I don't want to hear the input from the nurse or, heck, even, the medical student or whoever, because everybody, weren't you talking recently, Suzanne, about a case where it was like the medical student brought something up and was like, hey, I just read about this and it was some rare condition and it was exactly what the patient had. Didn't you say
Yes.
something about that recently?
Yeah.
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 So,
Everybody does bring a little bit different. And I had to learn that when I was teaching nursing students who had a degree in something else. I mean, when they came to
mm,
nursing school, they had a degree in something else. And I was a grad student. Before that, I was a grad student with those other students. And I thought, I'm going to go in here and they're not going to know anything because I have 10 years of nursing experience, and they have none. And how do they know what they're talking about? But it was really interesting to hear what they brought to the table, especially in some of those group discussions that you would get into in your school. But then when I taught those students, I realized, man, not only were they really smart, but they also had a different perspective. And I think that that's the beauty of working with a team. And it is a team sport, healthcare.
Yeah.
Mm-hmm.
And you have to respect each other's viewpoints, but abilities and skills and knowledge. And
Yeah.
it's it makes it a team.
I mean, I remember back to my training, and like I've always had held nurses in very high regard and very much valued nursing perspective and nursing roles in taking care of patients. That's just, and I think for me, that came from my residency training and particularly my internship year, where there was very little um, attending and sometimes even chief resident supervision, just put it bluntly. This was the 90s, things were early 90s, and things were very different. And I mean, it was the best of times and the worst of times in many ways, right? But you didn't survive without the nurses. And I can remember being on call in the intensive care unit, the surgical intensive care unit. And I was one of the first responders for code, and I just barely learned ACLS, much less practiced ACLS, right? And I would fall asleep, or not really fall asleep, but I would go to the call room to lay down, right? And I would have my little cheat sheet handbook. We called it our peripheral brain because we didn't have phones. You had a
Yeah.
pager, you didn't have phones. So I had my peripheral brain with all my little handwritten algorithms or things I would cut out from a book, like copy and cut and paste and all this stuff, like in my pocket. And I would fall asleep with it like next to my pillow for 10 minutes. And then I would get a call from the nurse using my maiden name. Doctor, this patient is, doing whatever, seizing, having this arrhythmia, whatever it may be. What would you like me to do? And I would be like, literally, well, what would you normally do in this situation? Without
Yeah.
hesitation. And they would say, well, normally we would do XYZ. And I would say, okay, do that. I'll be right out. And I'm looking it up. Was that the right thing to do? Whatever. And then I would go out and, okay, yeah, thanks for saving my ass and his ass,
Yeah. But when you say that, I'm tearing up because from a nursing perspective, I haven't always been treated that way.
Mm.
And I remember when I first started working with you and the respect that you showed me. And it was really meaningful, is what I'm trying to say, that you have always shown respect to nurses. And no matter their education level or um, their knowledge, their abilities, you've always been so respectful. So I don't know why I'm crying. Because we've worked together for so long, and I've told you that 100 times, but I don't know, it just really hit me right
Thank
now
you.
because as from a nursing perspective, that's so important.
Yeah. And I think it's such a sharp contrast, particularly to how we were treated at the beginning of our careers.
Uh-huh.
And maybe, I got better in teaching hospitals for me anyway. Because I felt more in a collegial role with the residents and the interns because they were running the board
Mm-hmm.
and they didn't know. I mean, and you got to know each other. And
Yeah.
I think that kind of brings me to another green flag is when hospitals take the initiative to teach team skills and how to build teams to the people working with inpatient care, not just educators, but helping them to know, hey, this is respectful communication. This is a good way to communicate. This is a way to delegate. This is a way to bring up concerns and issues and talk through it. This is a way to go up the chain of command respectfully
Yes.
with your colleagues. So I think when hospitals have that type of culture and have had that type of training, that's a huge green flag for me.
Yeah.
Absolutely. I mean, Suzanne, you're touching my heart right now. I didn't.
But why? It just really hit me, but
Well, I haven't thought about I really haven't thought about where that came from. But I mean, nurses have saved my tush so many times. But I'll tell you, I also witnessed a lot of bad treatment of nurses early in my medical training. And it was so appalling that maybe I just kind of took it as an ally situation, but like we're allies in this. Like I was an intern and a resident hit a nurse, flat
oh
out
my
socked her.
gosh.
Like, talk about needing some team skills and some communication training. Now, that resident was fired, but like that was the level of conflict that I've witnessed in hospitals before. And let's be clear, that wasn't the only time I've witnessed that level of conflict in a hospital. And it's
Yeah.
absolutely unacceptable. Like, it's just,
Yeah.
I know some of you listening are like, she's making this up. That's not real. It's 100% real.
Oh yeah. I had a metal tray thrown at me.
Oh,
I've
yes.
been cussed out. I've been
Phones
screamed out.
thrown.
Oh
Screaming
yeah. I
was
mean,
nothing.
so
Yeah.
many, bad behaviors. But
Mhm.
I guess a green flag would be as if the hospital doesn't tolerate that.
Bingo.
And but we've all been in hospitals where it was. And
Because usually the person doing it is a physician, usually.
eh,
And usually that physician is a big money maker. They're bringing in cases and patients, and so the behavior is tolerated, and that's unacceptable. Now, we've all behaved in ways that we aren't happy with when we look back at, usually for a variety of reasons.
Absolutely.
But what we're talking about is just basic respect for what people bring to the table.
but I'm going back to kind of Julie, your green flag. It's part of the reason that brings those teams together and you build that respect is when you learn together,
Yes.
which is a green flag for me, is when you do interprofessional education. And honestly, I don't know why every hospital does not have learning fetal monitoring together, for
Right.
instance. Why?
Yeah, like we talked about in the red
That was
flags episode. Yeah, you got to train together for fetal monitoring.
You have to. And it's just shocking that as a nurse that is required to go into fetal monitoring every 2 years at least, that I'm going to go to a physician that has not had fetal monitoring training, maybe even ever formalized, just on the job training. So, yeah, I mean, I think a green flag is definitely training together.
And fetal
Yeah.
monitoring is the easiest way to get everybody to train together. Like, it's so simple.
Easiest. Like, what would you call this? And what would you want to do about it? And, what's your opinion on this? And let's talk it out. And, so easy.
Yep. Yep.
It's a green flag. So you have a green flag from us to go out and start fetal monitoring training at your hospital that's interprofessional. And that could be as simple as even strip rounds
Yeah.
Yeah,
on an interesting case that you had. Okay.
Definitely.
that doesn't
What's
take
another-
any money.
Yeah. Well, what costs
Unfortunately.
money? Lawsuits.
Yeah.
Yep.
How much is the budget for the suit?
Yep.
Mm-hmm. Exactly. Okay, I've got another green flag.
Okay. Don't make me cry this time.
Well, I didn't think I was going to make you cry there.
I didn't either.
Oh, thanks for saving my butt, Suzanne.
Probably never did.
Yo, you did. Suzanne, I know that you're not on shift tonight, but we've got a patient here who's hemorrhaging and is in shock. And I would really love you to be at the bedside with me because I need someone who can help me with this. I'll be right in.
Yeah.
Yeah.
Mine is structure. I call it structured autonomy. Okay. So the days of cowboys and cowgirls are over. Okay. We can't have people doing out of, like just doing it. That's just the way they do it. We know they're crazy, whatever. But, we know that the guidelines say we shouldn't do it this way, but they have this new way of doing it. They think it's fantastic, whatever. I don't know. Structured autonomy. What I mean by that is we have guidelines and protocols that are evidence-based, where evidence is available, that say this is how we do it here. But we respect the individual's experience, training, and ability to make educated decisions, but not in a disrespectful, like, don't question me, this is the way it's going to be. um it's a fine line, I think, but nurses, physicians, advanced practitioners, whoever, they need to have some autonomy to practice, but under a structure that surrounds them, so that they don't get too far out doing wackadoodle stuff
I'll give you a
because
good
they're nice or charismatic.
right. I'll give you a good example of when that works really well that I've seen. Is with induction of labor, and the category 2 strip occurs, which occurs in the majority of labors. Let's say it's getting down towards the second stage of labor, where we know about 70 to 80% of tracings during that time will be a category 2 strip at some point. And you have Pitocin going, and that structure within your either Pitocin checklist, in-use Pitocin checklist, or your clinical guidelines say that you should do these things, or maybe even your training told you not to run Pitocin at that time or to go up on it at that time. But in this particular patient, and based upon your assessment of the fetal heart rate pattern and the uterine contraction pattern, a conversation is had between the nurse and the physician or midwife, and it is determined that at that particular time in this particular patient, you're going to deviate from the checklist and or the clinical guideline, and the rationale is A, B, and C. And that's documented in the medical record by the team. That is a perfect example of structured autonomy, to where a physician or a midwife can make that decision, and it's totally within reason of what because that patient needs that particular deviation at that time based upon your assessment, and that's not a violation of the standard of care.
Correct.
I think it also guides documentation, because when you're in the guardrails, and when you're getting close to a guardrail, you need to document and write your rationale. Doesn't mean you can't do it. You just need to let people know what your thought process was, why you are doing what you're doing for this particular patient, because you're not going to remember.
Same thing with early warning signs. You may have an assessment that's outside of the norm, let's say heart rate, and you note it, you communicate it, and the plan is to determine the cause, right? And the cause is still questionable, so you're going to do this, this, and this, instead of just slap a beta blocker on it, or instead of assume that it's due to pain or anxiety or something like that. So there's a thought that's called critical thinking, So you have the structure, but the autonomy of the physician or midwife is to help set that plan of care and to continue down a certain pathway, or to discover the rationale. So another structured autonomy.
Which kind of feeds into another green flag, which is safety for questions. Because it's hard to have structured autonomy if you don't have safety for questions. Because when you're going to be autonomous and deviate from a guideline or whatever, let's say as a physician, then the people around you and you as the individual need to be able to ask questions safely. And you're not just, we're not going to be hit, but like safely, like you're not going to be belittled. You're not going to be shut down. Your questions are going to be answered. Now, I'll put a caveat onto that. It's not always the right time to have an in-depth discussion about the decision. Okay. But at some point there should be an opportunity to have questions. I know Julie's got some thoughts on that, but it might not, if my hand is in a patient and I make a decision about something, that might not be the best time to have the conversation about it. But at some point there should be safety. So it's perfectly okay to say this, let's discuss this after or whatever, but the discussion has to take place.
Yeah, and I think when you practice as a team and that practice builds trust. This is why I'm doing this. And I love to do something that I call deliberate practice, where you take a complex situation and you take it step by step and you explain this needs to be communicated. This is what I need to hear at this time. I need to hear this and I need to hear it from this person. Or are the resources I need. This is the rationale why I need these resources. And this is my next step. This is what I'm thinking is going to be my next step. Or this is when I need to look over at the checklist and see what's on the checklist because I know I've got some decision points coming up. But when you practice that way, you build trust. You trust that person because you understand some of their thought process. You understand how they think. You understand um, how they're going to function in an emergency. And I think we've all been in emergencies where everything just went seamlessly. And it's usually with people people you've worked with a lot, people that you trust. You know them, they know you. Everybody understands what their skill sets are, and you just work together. And there's no way to achieve that. So I love your green flag of interprofessional education and training, because that is where you get to that point in the practice and performance of patient care, not just with the team that knows each other, but with the entire unit.
Well, it sets the groundwork for safe place to ask questions. Like
Yes.
if you're doing SIM as an interprofessional team and the guide on the side is is prompting and guiding, then the team is going to start asking questions.
Yes.
And it becomes that behavior of asking questions about what happened and why, and what people need and what worked well and what didn't. All of that, it just becomes part of the culture.
Yes.
Yeah.
Yes. And they're not expecting you as the simulation instructor to answer the question. You reflect back to them and they answer their own question.
Right.
And that process even is educational and team building.
Yeah.
I mean, that's human nature, right? Like we watch people around us making decisions that we wouldn't make. And we're like, well, they've got to learn it on their own. They got to figure it out on their own. Like we learn better by experiencing it ourselves than by somebody telling us what will happen if we do such and such a thing.
Yeah.
Well, and I think it's such a contrast from what you do in school. A lot of times in school, depending upon the faculty, they may drive towards memorization. And really what we're driving towards is understanding the why and understanding. And when you understand the why and the rationale behind what you're doing, and that would include team roles and team needs, right? What we've been
Yes.
talking about,
Yeah.
then it helps you remember those things. It helps you to function better as a team. It helps you it's not a memorization. It's practice.
Yeah. Yeah.
Well, and it makes things work better. Like, for example, in my outpatient practice, my medical assistant I teach her a lot. I, assume that she has the ability to learn, and she absolutely does. And it makes my life easier because now she can anticipate what is going to happen, what I'm going to need, what I'm going to want, what kind of questions I'm going to be asking the patient. She knows I want to know everybody's ferritin level, but I explain why and talk to her about. So that means now the rest of the staff, because she's the one I interact with, with every single patient, right? So now the rest of the staff understand that it's okay to ask questions. I can tell you that it does not impact the flow of my day negatively. It does the opposite. It makes my days go smoother because everybody understands what I'm doing and why and how I'm thinking and what the patient might need. And so whether they're scanning a patient or checking in a patient or checking her vital signs or whatever it may be. It all helps when everybody is comfortable asking questions. And as a provider, it can get a little overwhelming. You're like, oh my God, everybody's going to be asking me questions all day long. That's not it at all. And if it is, there's many a time where I'll say, now's not the right time. Remind me later, and I'll be sure and go over that with you.
Well, all of these go back to a just culture in your organization, which is what you need to be a high, reliable organization.
Explain to the listeners what you mean by a just culture.
Well, all of the components that we've been talking about.
Yeah, basically,
that you respect each other, that you are an interprofessional team, that you have the ability to speak up and ask questions and to understand the why, and to all of those
Yeah.
things go into a just culture.
Yeah.
Where patient safety is the number one priority.
Mm-hmm.
And to get that, I think that, which is just one component of a highly reliable organization. To get that, I think you need to be proactive versus just being a reactive, which again is our tagline, but to really look for those opportunities to change practice, to change culture, to change your organization, to become more reliable, to become safer, to become more trusting, to become, more, have that collegiality, because we've all worked in organizations that didn't have that, but we've also worked in those that did. And the teamwork is so much better when you have those components of being highly reliable.
I think that leads me to another green flag that I have, is when you practice with the intention of improving process. And once you have smooth process, you have role delegation, you understand how you're going to work together, you decrease chaos. And I think a just culture is much easier to achieve when you're not chaotic. I mean, not to say that labor and delivery isn't, or even postpartum, wherever, is not going to be chaotic at times. I mean, it is always going to be chaotic at times. But when you have processes down, when you actively work to refine your processes to decrease chaos in emergencies, it's so much easier to be respectful and to speak up because you have that assurance that it's okay. And you have the assurance too that the patient's being taken care of, because one of the main team skills I think that's really important is situation awareness, not just of what's happening in the room, but what's happening with the patient. And once you hardwire that into your process, it becomes so much easier to have a just culture, I think.
Yeah,
I agree.
We were kind of talking about that the other day, and it's always been easier for me and my personality to speak up, but I've seen in most situations, again, I cried because I've been in situations where it was scary to speak up, right? And I remember when I was a newer nurse that I still spoke up. And, I think I was even a GN when I first started speaking up. I know that's not shocking to many of you, but I'm really not. I am a Libra. I do
What
not.
does that mean?
I do not like confrontation. I am very harmonious. People think that's hysterical when I say that. And I'm like, I really am. I do not like, internally, I do not like to have confrontation. And I'm not saying you speak up in a confrontational way. It's just always been easier, again, from my personality to say, hey, can, wh- tell me about why you're doing that. I want to understand, or, hey, I need to talk to you about this order because I don't agree with it, or whatever it is. I've never had a problem doing that. So I think a green flag would be that training or that person on your unit that knows the people that they're working with and knows that sometimes they're going to have to step in for the people that don't have the same personality type or don't have that, it's not as easy for them to speak up. And I'm really talking to the charge nurses out there, that know their staff, that how can I best facilitate patient safety on the unit this shift when I have these staff members that are working, and will I need, I can see what's going on the fetal monitor strip, maybe checking in with that staff nurse to say, hey, what's going on with your strip? How can I help? Has the physician or midwife, if you talk to them, and maybe involved to support them and to help them develop that skill. It's not that you're going to do it for them. The rest of you're helping them that are newer or they don't have that ability at that time or that confidence, I think, to help them develop that and to understand the rationale so that the next time they feel more confident in doing that.
I think that the confidence is key, and that comes from knowledge. Like if you don't understand what needs to happen, what is happening, what has happened, you're going to be hesitant in more hesitant in an interaction, particularly if, you're intimidated in some way, shape, or form, whether it's intended or not, by the person you're having to interact with. I know I have intimidated people throughout my career, not because I'm intentionally being intimidating, but I know that people do get intimidated. And so I can imagine that there are times where it's harder to speak up as a nurse, for sure. But when you understand what you're doing and why, it makes it easier to speak up because you can't not speak up. Like, for example, if you know your patient has preeclampsia with severe features, needs to be on MAG, needs steroids, and needs her blood pressure treated, you can't accept those things not happening as the nurse. Like, it's not a personality thing. It's I can't take care of this patient in this way because this is not the right medicine. And then it's a matter of how do I communicate that? And yes, personalities come into it, but the more confident in you are in what needs to happen, then the easier it is to actually have those interactions. And then, of course, that's where guidelines and
so I want to give a green flag,
all that kind of stuff,
But I want to give a green flag to all those nurses out there that are scared to speak up sometimes, that they do have that fear because of a lack of confidence, and it may be because they're newer, maybe because they don't have the knowledge about a certain high risk condition that the patient has. Think of it in a learning way. You are learning because the next time you're in that situation, you want to have that experience, and you want to understand the why, and just say, hey, I want to ask you a question. Help me to understand this, because I do that on a daily basis. Number one, I'm never going to know everything. Number two, I don't know the answer all the time, and I want to learn. So that's another green flag would be lifelong learning. And that mindset that I'm going to learn something every day that I go to work. Every day I'm going to pick up something else that I need to understand to better take care of patients.
Kind of amazing.
Yeah.
Well,
that mindset.
Maybe that's a good place to wrap it up today. I like that. Never stop learning.
Yes.
I don't want to cry anymore.
No more crying. There's no crying in podcasting.
I guess there is now.
All right. Well, thanks everybody for listening to the Critical Care Obstetrics podcast. Don't forget about our online CCOB Academy at clinicalconceptsnob.com, and support our ability to keep doing what we're doing by joining us on Patreon at patreon.com/CCOB. You can find us on YouTube and check us out on all our social media. We want to know your green flags.